अच्छा इसको कभी करना है कभी नहीं करना है. मैं आज उसी में से इसको रख दीजिए, ज़रूरत होगी तो फिर मैं ओके. So today we will discuss the mitral valve disease, mitral stenosis as well as mitral regurgitation. Both these diseases are very important point of view in future clinical practice. For your exam also it is very important. When we give a case of CVS as a short case, as a long case, we always give a case of mitral stenosis. Valvular heart disease, that means mitral stenosis. It is must, it is mandatory, we have to give the case of the mitral valve disease. So this is important. When we discuss the X-ray, we discuss the ECG, X-ray viva, ECG viva, drug viva, all these areas the mitral stenosis is important. We always keep a X-ray of the mitral stenosis. We always keep the ECG of the mitral stenosis. So everywhere the mitral stenosis is important. Mitral valve disease is important. आप सारे लोग सब पीछे क्यों बैठते हैं? Why you are not sitting in front? I am not asking anything. ये भी नहीं चलता है. Sometime चल रहा है अभी? Yes, okay. ठीक है. So in the last class I sensitized about the anatomy of the mitral valve. So this is the mitral valve, that is the anterior leaflet, posterior leaflet, papillary muscle, chordae tendineae. These are these all combined make the structure of the mitral valve. Now mitral stenosis, the etiology, when we discuss the etiology of the mitral stenosis, there is only one etiology, that is the rheumatic heart disease. So 99.9% cases mitral stenosis due to the rheumatic heart disease. There are very rare causes of the mitral stenosis like large vegetation of the infective endocarditis, LA myxoma, बहुत बड़ा LA myxoma है, that is obstructing the orifice of the mitral valve. So LA myxoma, valve thrombus and coatriatrium. These are very rare causes of the mitral stenosis. Again, the less common causes are the malignant carcinoid disease, systemic lupus erythematosus, rheumatoid arthritis, mucopolysaccharidosis, Fabry disease, Whipple disease, and methotrexate therapy. In methotrexate therapy, there is a fibrosis of many structures including the mitral valve. So these are the etiology. But once someone asks you what is the etiology, the rheumatic heart disease come first, because 99.9% cases of the mitral stenosis, they have the history of acute rheumatic fever, right? Again, the mitral stenosis, it is a slowly progressive disease. All of you know the valve area of mitral valve, it is near about 4 centimeter square normally. So whenever your patient have the recurrent episode of acute rheumatic fever in the age of 10 to 15 years, because the age for the acute rheumatic fever is 5 to 15 years. So if your patient have the recurrent episode of acute rheumatic fever, in particular childhood age, school going age, then the disease start. So the mitral valve start to fibrosed, thickened, and the structural deformity started at the age of 15 years. When the patient have the recurrent episode of acute rheumatic fever. So the 4 centimeter valve area, the patient remain asymptomatic for up to 10 years till the valve area become less than 2 centimeter square. It take near about 10 to 15 years. 4 centimeter का valve 2 centimeter तक आने में 10 to 15 years लग जाते हैं. So suppose the patient have the history of acute rheumatic fever at the age of 15 years, the patient becomes symptomatic when the patient become at the age of 25 years. So usually the patient present clinically and the patient becomes symptomatic within 20 to 30 years. Another one, if there is a ASD with rheumatic mitral stenosis, that condition known as Lewton-Baker syndrome. Now this is the hemodynamics for the mitral stenosis. So what happened in mitral stenosis? First the valve size is reduced. So there is the flow from the left atrium to left ventricle is reduced. There is increased pressure gradient between the left atrium and the left ventricle in the diastole. Then there is a backward flow. So there is a increased pulmonary venous congestion, then capillary congestion, then pulmonary arterial pressure raised. And when the pulmonary arterial pressure raised, there will be thickening of the muscular layer of the pulmonary artery. So ultimately the patient develop pulmonary artery hypertension. Because of the pulmonary artery hypertension, there is a right ventricular hypertrophy or dilatation, and ultimately the patient develop functional TR, and patient, because of the functional TR, there is a right atrium dilatation and ultimately the right sided heart failure. So this is the hemodynamics for the mitral stenosis. In mild to moderate cases of the mitral stenosis, the patient usually remain asymptomatic, and they become symptomatic only when the patient have to exercise or any condition that increase the heart rate. Now what is the correlation between the heart rate and the symptoms? Because the diastolic, the blood come from LA to LV in diastole, and whenever there is a tachycardia, there is cut down of the diastolic phase. Nothing happen with the systolic phase. So jitna tachycardia hoga, the diastolic phase becomes shorter and shorter. Already there is a mitral stenosis, less amount of the blood going from LA to LV, and if we cut down the diastolic phase, further reduce of the flow from LA to LV. So the patient becomes symptomatic. In severe cases, the patient remains symptomatic all the time. Another hemodynamics. So if the patient, if there is a increase in LA pressure, the LA size will increase, and once the LA size will increase and it cross 4.5 to 5 centimeter, the atria start fibrillating. So there will be atrial fibrillation. Now the filling of the LA to LV depend on the atrial contraction, because the valve is stenosed, and if the patient develop the atrial fibrillation, that active contribution of the atrial contraction gone. So further the patient become symptomatic immediately. So once the patient develop AF, clinically the patient become decompensated by two mechanisms: loss of atrial contraction, number one, and because AF sometimes most of the time the AF have the fast ventricular rate. So again the fast ventricular rate, that means tachycardia, that means further cut down of the diastolic phase. So no atrial contribution and reduction of the diastolic phase, ultimately the patient become more and more decompensation. So this is the hemodynamics of the mitral stenosis. Is it clear how the patient becomes symptomatic? Clear everyone? Now when we take the history of the mitral stenosis patient, so usually the patient remain asymptomatic at the rest during the early stage of the disease. When there is a mild mitral stenosis, that means the valve area is more than 1.5 centimeter square, though it is less than 2 centimeter square, but it is more than 1.5 centimeter square. So, in mild cases the patient usually remain asymptomatic, and they become symptomatic whenever there is an increased heart rate. So, what are the conditions in which the increased heart rate the patient becomes symptomatic? Patient remain asymptomatic in routine activity. So, increased heart rate such as fever, severe anemia, thyrotoxicosis, exercise, pregnancy, or in atrial fibrillation. So, all these conditions, if there, these are the precipitating factor for the mitral stenosis decompensation. The disease already is there, but the patient is in compensated position. So, patient is doing his or her routine activity without any discomfort, but whenever there is increased heart rate due to any reason, the patient become symptomatic. Another presentation, sometimes the patient give you history of the systemic embolization that may cause stroke, renal failure, or myocardial infarction. And you know why there is a stroke systemic embolization? Because in AF the atria is not contracting, so the blood is not passed from LV, LA to LV. The blood is stagnated in the left atrium. Once the blood is stagnated in the left atrium, there is a thrombus formation, and once thrombus formation, it embolize and gives systemic embolization. Sometimes the patient give you history of the hoarseness of voice, and this hoarseness of voice due to the compression of the recurrent laryngeal nerve, because the laryngeal nerve, recurrent laryngeal nerve, it passes behind the pulmonary artery and left atrium. So, once the pulmonary artery is dilated, left atrium is dilated, it compresses the recurrent laryngeal nerve and patient develop hoarseness of voice. There is also compression of the left main bronchus, so the patient have recurrent history of cough. The cough may also be due to the pulmonary congestion or the pulmonary edema. Many times the patient give history of the hemoptysis, and that hemoptysis is due to the pulmonary edema, and usually there is a pink frothy sputum. Patient also have the history of palpitation, and palpitation because of LA enlargement, number 1, and whenever the patient develop atrial fibrillation, patient give history of palpitation. Chest pain due to the pulmonary hypertension, where patient usually present with edema and ascites, bilateral pedal edema and ascites because of the right sided heart failure. Many times the pregnant women, they become symptomatic in the second trimester of the pregnancy, because in the second trimester of the pregnancy there is a volume overload. So, the patient, compensated patient become decompensated. Another one, because of the volume overload, there is a hemodilation and patient develop physiological anemia, that also contribute for the symptoms of the patient. Clinical manifestation, that already we have discussed. The patient have the dyspnea, hemoptysis, thromboembolic phenomena, chest pain, infective endocarditis, right sided heart failure, hoarseness of voice, also known as Ortner syndrome or cardiovocal syndrome, and fatigue due to decreased cardiac output. On examination, so first appearance, there is a mitral facies. It is a pinkish purplish patches on the cheek like this, that is due to the chronic severe mitral stenosis due to reduced cardiac output and vasoconstriction. So, patient have this type of the facies. Jugular veins, they remain distended or the dilated because of there is a functional TR and there is a more blood in the right atrium. So, there is a prominent A wave and there is a prominent V wave whenever there is a functional TR. So, but for you it is sufficient the JVP is raised. On palpation, so cardiac palpation, we always start with the pulse. So, pulse, what will be the pulse? Less amount of the blood passes from the left atrium to the left ventricle. So, the less amount of the less cardiac output, so the pulse become low volume pulse, and if the patient have atrial fibrillation, so it will be irregular pulse. So, pulse usually low volume pulse and irregular rhythm. Apex impulse, yes, it is in the mitral stenosis the apex become tapping apex. That means whenever the less amount of the blood in the LV is in globular shape, so the apex impulse, suppose the apex impulse is like this area is the apex impulse, but whenever there is a less amount of the blood in the LV become conical in shape, so the apex is like pointed out apex. We can feel that apex with tip of the index finger. So, the apex is localized and it is in the 5th intercostal space normal position, but it is very localized that we can feel, we can find out by the tip of index finger. Tapping apex will be there. There will be left parasternal heave. All of you know, we discussed in the previous classes the causes of the left parasternal heave, because just behind the left parasternum there is a right ventricle. So, in any causes of the dilatation of the right ventricle, there will be left parasternal heave. So, left parasternal heave may be there. P2 may be palpable. P2 may be palpable in the pulmonary area, and pulmonary area is the second intercostal space on the left side, that is the pulmonary area. So, whenever there is a pulmonary artery hypertension, P2 will be palpable. So, these are the palpatory findings of the mitral stenosis. On auscultation, yes, on auscultation the first and most important thing is the S1 become loud. So, S1 is accentuated, because what happened, suppose this is the 2 leaflet of the mitral valve. If they are, this is the normal movement, normal opening and closing of the mitral valve, and suppose this is thickened, fibrosed, lot of fibrosis, thickening, abnormal leaflets. So, the movement become jerky like this. So, the mitral valve close like this. So, whenever the jerky movement and sudden closure of the mitral valve, it will produce the S1 become accentuated. So, S1 is loud whenever the rhythm is sinus. But if the patient have atrial fibrillation, what will be the S1? S1 will be in variable intensity. Some beats loud, some beat muffled, some beat soft, some beat absent. So, S1 whenever the sinus rhythm is there, in mitral stenosis S1 is loud, but if atrial fibrillation is there, the S1 become variable. Next is the loud first heart sound, okay. Then mid diastolic murmur. Another auscultatory finding, another important diagnostic point is on the auscultation in the mitral stenosis is the MDM murmur, mid diastolic murmur. As you know, the blood passes from LA to LV in the diastole. Whenever there is a stenosis, so blood pass with the stenosed valve, there is a turbulence of the flow and that produce the murmur. So, patient have the mid diastolic murmur. If the patient have the pulmonary edema, you may get the crepitations, there may be effusion, pleural or the pericardial effusion. So, S1 is accentuated because of the stenosed valve, S1 become variable because of the atrial fibrillation, and sometimes the S1 is decreased in intensity, because as we know the valve, whenever the valve is thickened, it produces the loud S1. But whenever there will be the calcification and there is a no movement, the valve become rigid. At the end of the disease, the valve become rigid, lot of calcification over the mitral valve. So, the valve is not open or close, it remains stand still, that cause the soft S1. So, sometime the examiner may ask you ki, a patient of the pulmonary mitral stenosis and what are the causes of the soft S1. So, you can say ki whenever the valve is stenosed, critically stenosed with calcification with no pliability in the valve, the S1 become soft. Second heart sound, yes, in initial stage when the pulmonary artery hypertension is not there, the S1 remain normal, but whenever there is a pulmonary artery hypertension, the S2 or the P2 become loud. There is another important characteristic finding in the auscultation, that is the opening snap. As we know, because of the fibrosis, the closing is jerky, the opening is also jerky. So, opening snap is a sound when the fibrosed valve suddenly open. जैसे कि किसी जाम खिड़की को जब हम ओपन करते हैं तो एक साउंड आता है, एक अजीब सा फक टाइप का साउंड, दैट इज द ओपनिंग स्नैप. सो द क्लोजिंग इज जर्की, इट प्रोड्यूस लाउड S1. The opening is also jerky, like this. It produce the opening snap. So, opening snap is another auscultatory finding of the mitral stenosis, and it give you clue that still the valve is pliable. Whenever the calcification is there, opening snap will absent, S1 become decrease in intensity. Clear? We can also diagnose the severity of the mitral stenosis by the S2 opening snap gap. Shorter the S2 opening snap gap, more severe mitral stenosis. So, these are the auscultatory findings of the severe mitral stenosis. S1 become accentuated, S1 is loud, P2 is also loud. There is a S2 opening snap gap. If it is shorter, more severe disease, MDM murmur and presystolic accentuation. So, if someone asks you what are the auscultatory finding of the severe mitral stenosis, these are the 6 components that you should answer: loud S1, loud P2, OS S2 gap will be reduced, MDM murmur and presystolic accentuation. Sometime the examiner may ask you the differential diagnosis or the other causes of the MDM murmur. Mitral stenosis, of course, the most important cause of the MDM murmur, but what are the other causes of the MDM murmur? So, yes, Carey-Combe murmur, this is the murmur of the acute rheumatic fever, carditis. In acute rheumatic fever, there is a pancarditis that we discussed in the last class. In pancarditis, they are all the layer of the heart they involve. So, whenever there is a endocarditis, there is a valvulitis, the valve becomes swollen, inflamed, and that produce the MDM murmur, that is the Carey-Combe murmur. Next one is the Austen-Flint murmur. It is also a mid-diastolic murmur and it present in severe aortic regurgitation. What happened in aortic regurgitation? The LV, during the contraction of the LV, the blood passes from left ventricle to the aorta and some amount of the blood leaches from aorta to the left ventricle, and that jet touches the anterior mitral leaflet. So, anterior mitral leaflet is vibrating, that produces the Austen-Flint murmur. So, Austen-Flint murmur, it is a MDM murmur due to the severe aortic regurgitation. How we can make difference between the Austen-Flint murmur and the MDM murmur of the mitral stenosis? In mitral stenosis, S1 will be loud, right? There will be opening snap, but in aortic regurgitation, the S1 will not loud and there will be no opening snap, and there will be sign of peripheral sign of the aortic regurgitation. So, by this we can make difference. This is the MDM murmur of the MS, or this is MDM murmur of the aortic regurgitation. So, this is the Austen-Flint murmur. Now, MDM murmur of the mid-diastolic murmur of tricuspid stenosis. So, if the tricuspid stenosis, it also produces the mid-diastolic murmur. How can we make the difference? Tricuspid stenosis, the murmur will increase during inspiration. The MS murmur, it will increase during expiration. So, all right-sided murmur, they increase during inspiration, all left-sided murmur, they increase during expiration, and this sign is known as de Carvalho sign. So, these are the differential diagnosis of the MDM murmur. There may be Caricombe murmur, there may be Austin Flint murmur, MDM murmur of the tricuspid stenosis, or MDM murmur of the high cardiac output state. These are the causes of differential diagnosis of the MDM murmur. This is the classification according to the severity of the mitral stenosis. So, mild when the mitral valve area is more than 1.5 centimeter square, moderate when valve area is 1 to 1.5, and severe when the valve area is less than 1 centimeter square, and critical when the valve area is less than 0.8 centimeter square. Investigation. In every cardiac disease, ECG is the prime investigation. So, in the ECG, we will get the sign of LA enlargement and right ventricular hypertrophy plus rhythm abnormality. Rhythm abnormality, that is the atrial fibrillation. So, these three things we see in ECG. X-ray, again LA enlargement and sign of the pulmonary venous congestion or the pulmonary edema. In echo, we can directly visualize the structure of the mitral valve, the thickening, fibrosis, opening, closing, calcification, all these things we can visualize by the echocardiography. So, this is the X-ray of the mitral stenosis, and in X-ray we can see the pulmonary conus, pulmonary main artery, it is dilated, the pulmonary conus is filled on the right side as well as on the left side. There is a straightening of the left border of the heart that give you clue of a LA enlargement, and even there is a convexity. Usually there is a concavity like this, but in this there is a convexity. So, the LA is enlarged, pulmonary conus is full, main pulmonary artery is dilated, and there is a Carle A line and B line. So, Carle B line, it is there is a transverse line at the base of the lungs that indicate pulmonary edema, and there is a cotton wool appearance of the pulmonary edema. So, these are the findings in X-ray chest of mitral stenosis. There may be right ventricular enlargement also. This is the ECG, and in ECG we can see this is the P wave, broad P wave, it is just like a P mitral. Because of the LA enlargement, the P wave become broad. Because of the RA enlargement, the height of the P wave become long. The left atrial enlargement, the width of the P wave become broader. So, P mitral, P pulmonale, P pulmonale, right atrial enlargement, P mitral, left atrial enlargement. So, you can see the width of the P wave, it is more than 2.5 small segment. Now, in V1, normally the V1 there is no R wave in V1 normally, but in this you can see there is a tall R wave, it is more than 5 millimeter. It gives you clue there is a right ventricular enlargement. So, right ventricular enlargement in the ECG we can see in the V1 positive R more than 5 millimeter. So, RVH is there, P mitral is there. In this rhythm you can see this is there is the RR interval, variable RR interval. Variable RR interval will give you clue of the atrial fibrillation, and there is a no P wave, variable RR interval, this is the atrial fibrillation, and in another these are the fibrillatory wave. These are not P wave, these are the fibrillatory waves. So, atrial fibrillation in the ECG, atrial fibrillation is there, in RVH, RV enlargement is there, LA enlargement is there. In 2D echocardiography, this is the normal mitral valve in the opening position, this is the anterior mitral leaflet, this is the posterior mitral leaflet, and wide area of the mitral valve, normal area of the mitral valve. And in this you can see the LA, first the LA is enlarged, the RV, this is the RV is also enlarged, this is the normal RV, You can see this is the big RV, this is the normal LA, this is the big LA. The mitral valve, it is fibrosed, thickened, the anterior mitral leaflet, this is the normal leaflet, this is very thickened leaflet, hockey stick type of appearance, the tip is calcified, lot of fibrosis you can see, and valve area is little bit very small valve area, this is the very small opening, right. So, these are the echo findings. By the echo we can use the Wilkinson score system, because by this scoring system we plan the future of that patient, whether the patient need the balloon valvotomy or the patient need the mitral valve replacement. So, in this Wilkinson score we use the leaf mobility, the valve thickness, subvalvular thickening and valvular calcification. These are the 4 parameters we identify and we score according to the CVIT 1, 2, 3, 4. If this score is less than 10 or less than 9, we usually do balloon valvotomy, balloon valvoplasty, and if this score is more than 10, we usually go for mitral valve replacement. Management of the patient. So, in mild cases when the patient have the less symptoms, we manage the patient medically. So, we give the diuretic therapy to reduce the pulmonary congestion. We use the digoxin beta blocker or the calcium channel blocker to reduce the heart rate if the patient have atrial fibrillation with fast ventricular rate. So, we use digoxin, beta blocker and calcium channel blocker. And if the patient have the thromboembolic phenomena, so we give the anticoagulation to the patient. And if the patient remains symptomatic after the medical management, then we can go for the balloon valvoplasty, mitral valvotomy or mitral valve replacement. So, these are the prosthetic valve. There are 2 types of the prosthetic valve. One is the bioprosthesis, another one is the mechanical prosthesis. Again bioprosthesis is the heterograft or the xenograft. तो ये अदर एनिमल्स का यूज़ करते हैं इसमें. वी कैन यूज़ द पोर्साइन और द बोवाइन valve and allograft, that means अदर ह्यूमन बॉडी से निकाल के किसी दूसरे ह्यूमन बॉडी में ट्रांसप्लांट करना. सो दिस इज़ द allograft and autograft with the same human body with the use of the pericardium, or we can replace the mitral valve with the pulmonary valve. So, this is the autograft. Mechanical valve, again there are 3 types of the mechanical valve that we use, that is the caged valve, tilting disc and bileaflet. This is the bileaflet, this is the tilting disc, this is the ball in cage. So, these are the 3 valves which we use for the mitral valve replacement. Advantage and disadvantage. Bioprosthesis have their own advantage and they have their disadvantage. So, what is the advantage of the bioprosthesis? Because the patient does not need prolonged anticoagulation therapy. And what is the disadvantage of the bioprosthesis? This is because they have very limited lifespan, because they are made up of the tissue. So, the lifespan for the bioprosthesis is 5 to 10 years. Mechanical valve, the lifelong is more than 40 years, but they need lifelong anticoagulation therapy. So, we use the bioprosthesis whenever the patient have pregnant patient, because in pregnant patient the anticoagulation is contraindicated. So, इसमें हम कर सकते हैं. Then bleeding disorder, if the patient have bleeding disorder, then उसमें हम we use the bioprosthesis. Age more than 70 years. 70 years है 10 years और हो जाएगा. So, it sufficient for the patient. So, if the patient age is 70 years, we do give the bioprosthesis. Or poor compliance, that means patient not adherence with the anticoagulation therapy, तो फिर हम उसमें bioprosthesis. So, bioprosthesis. Otherwise, in all other conditions, because it is a disease of young, patient usually become symptomatic in 20s and 30s. So, up to the age of 25, to 30, the patient usually come to us with the critical mitral stenosis. तो पेशेंट को बहुत लंबा लाइफ जीना है, तो इसलिए हम लोग भी यूजुअली प्रिफर द मैकेनिकल प्रोस्थेसिस. Advantage of the mechanical prosthesis, yes, durability very high, but the patient need lifelong anticoagulation. Another one, hemolysis is less in bioprosthesis, hemolysis is more in mechanical prosthesis. Thromboembolic phenomena less with bioprosthesis, more with mechanical prosthesis. Important, the patient usually come to us, the patient remain the compensated stage because the mitral stenosis, it is a very slowly progressing disease. So the patient usually remain compensated long time. They usually become decompensated whenever there is a AF or increased heart rate. So patient usually come in AF. Management of the AF again important. So if the patient is hemodynamically unstable, we immediately give cardioversion. If the patient is hemodynamically stable, then we can use the digoxin, we can use beta blocker, we can use calcium channel blocker. If the patient is in failure, we use digoxin. If the patient is not in failure, we can use the beta blocker or the calcium channel blocker. And if the patient have the chronic AF, then we go for radio frequency ablation therapy. Radio frequency ablation, that is the permanent treatment for the atrial fibrillation. Complication, mitral stenosis is a very complicated disease, lot of complication with the mitral stenosis. So these are the complication of the mitral stenosis: acute left heart failure, acute pulmonary edema, pulmonary hypertension, right ventricular failure, atrial fibrillation, flutter, ventricular or the atrial premature beats, embolic manifestation, hemoptysis, infective endocarditis, recurrent bronchopulmonary infections because of the pulmonary congestion, complication due to the enlargement of the left atrium, that is the hoarseness of voice, dysphagia. There may be jaundice and cardiac cirrhosis because there is a liver congestion, right, because of the right-sided heart failure. So these are the complication of the mitral stenosis. Now, because the mitral stenosis have the associated thromboembolic phenomena, so we have to give the anticoagulation. तो किस पेशेंट में एंटीकोएगुलेशन देंगे, किस में नहीं देंगे, that we can assess by the Chadwick scoring system. If the Chadwick scoring system is more than 3, we give anticoagulation. If it is less than 3, we usually not give anticoagulation. So Chadwick scoring system, C stand for the cardiac congestive heart failure, 1 point, hypertension again 1 point, age more than 75, 2 point, diabetes 1 point, previous history of stroke 2 point, vascular disease, any other peripheral vascular disease 1 point, age 65 से 74 के बीच में है 1 point, and sex female 1 point. So if that scoring is, sum of that scoring is more than 3, we start anticoagulation. Now another one is the mitral regurgitation. So mitral regurgitation, again the valve is unable to close completely. So there is a leak of blood from left ventricle to the left atrium. Etiology of the mitral regurgitation, it is not like the mitral stenosis. In mitral stenosis, whole sole etiology is the rheumatic heart disease. But in mitral regurgitation, there are hundred of causes of the mitral regurgitation. So we divide in primary and the secondary. Primary, that means the valve disease, may be due to the rheumatic valvular disease, may be due to the dysfunction of the papillary muscles, rupture of the cardi tendini, may be due to the trauma, may be due to the mitral valve prolapse, or so there are many causes of the mitral regurgitations like MVP, rheumatic heart disease, infective endocarditis, annular calcification, cardiomyopathy and ischemic heart disease. Primary mitral regurgitation, that means disease in the valve. Secondary mitral regurgitation, that means any disease that cause dilatation of the left ventricle. So suppose the left ventricle is like this and mitral valve is closing like this. if the LV size become this, so the valve is normal, but because of the dilatation of the LV, there is a regurgitation. That is the secondary regurgitation, and this usually seen in the dilated cardiomyopathy or a patient of the aortic regurgitation. In aortic regurgitation, the LV become dilated. So, ultimately in later on stage, the patient develop mitral regurgitation too. Primary mitral regurgitation, secondary mitral regurgitation. Pathophysiology of the mitral regurgitation again depend on the onset. उसका onset क्या है? It is totally different from the mitral stenosis. Mitral stenosis, it is a disease of years together. It is a very slowly progressive disease. But in mitral regurgitation, because of the trauma, because of the MI, because of the rupture of chordae rupture of papillary muscles, there may be acute onset. So, presentation may be acute, may be chronic. So, pathophysiology depend on the onset. If the mitral regurgitation is acute, that means there is no time for compensation, no time for LA dilatation. Patient immediately become hemodynamically unstable because all the regurgitant blood go directly into the pulmonary circulation. So, presentation, pathophysiology depend on the onset. If your patient have the chronic mitral regurgitation, that means initially the patient have trivial leak, then the patient have mild, moderate, then severe. So, there is a time for compensation. So, first the LA become dilate, LA become more dilate, and it attain the maximum capacity, then the blood go to the pulmonary circulation. But in acute, directly, because there is no time for LA dilatation, so directly the blood go into the pulmonary circulation and immediately the patient become decompensated. So, in mitral regurgitation, the cardiac output, the LA is dilated. Because of the LA dilatation, there is atrial arrhythmias, thrombus formation, reactive pulmonary artery hypertension, right-sided heart failure, and in left ventricle, some amount of the blood regurgitate to the LA. Then again on the next cycle, large amount of the blood come in the LV, and this repeated again and again. So, LV volume is overload, there is a concentric LVH, LV dilatation, and ultimately there is a LV failure and systemic hypertension. This you can see, this is the normal LV and LA, the valve close normally and all the blood go into the aorta during LV systole. But in this acute mitral regurgitation, the blood go into the systemic in the aorta and some amount of the blood go into the LA, and directly because the LA is normal in size and there is no time for dilatation, it goes directly into the pulmonary circulation and pulmonary edema. In chronic mitral regurgitation, some blood go into the aorta and there is a LA dilatation. So, the most of the blood remain in LA, and whenever the LA is huge in size, then only the blood go into the pulmonary circulation. So, how we can differentiate whether it is a acute MR or it is a chronic MR. First, history will give you clue. The history of acute, that means MI here, so the MR is acute. The patient acutely decompensated, there is no previous history. The LA size is normal in acute, the LA size is huge in chronic. So, the symptoms, again symptoms depend on the phase of the disease. So, individual with acute mitral regurgitation, they immediately become decompensated, or the patient have the congestive cardiac failure, shortness of breath, pulmonary edema, orthopnea, PND, as well as symptoms suggestive of low cardiac output, that means the blood pressure is low, pulse is low. In chronic, all of you know, it is a high cardiac output state. So, the pulse is high volume pulse, the LA is dilated, and the patient usually remain asymptomatic in mild case, and they become symptomatic only whenever there is a precipitating factor. On examination, yes, The pulse again depend on the whether the MR is acute or chronic. If the MR is acute, there is a low volume pulse. If the MR is chronic, the pulse volume is high volume pulse. Blood pressure in acute MR, there is a hypertension. In chronic MR, there is a wide pulse pressure. Wide pulse pressure. JVP, it remains raised whenever there is a decompensation or there is a right-sided heart failure. Then on auscultation, the S1 is soft. In MS, the S1 loud. In MR, the S1 is soft or absent. The apex impulse, because of the left ventricular dilatation, the apex impulse is down and out. Again, in acute MR, the left apical impulse is remain normal in position. In chronic MR, the apical impulse is down and out and it is hyperdynamic in nature. There is a high pitched holosystolic murmur at the apex radiating to the axilla and best heard when the patient lying in the left side. There is no correlation of the loudness of the murmur with the severity of the regurgitation. So, there is a pansystolic murmur. In MS, the S1 is loud, MDM murmur. In MR, the S1 is soft or the S1 is absent. In the severe MR, there is a pansystolic murmur. There is a presence of S3 when the left ventricle start to fail. The S3 is always when the LV failure. S4 when there is a left atrial decompensation. So, S3 is a sound of ventricle, S4 is a sound of atria. So, there is a presence of S3 and the patient may have atrial fibrillation. These are the investigation. So, in investigation there is a left ventricle is also enlarged, left atrial is enlarged, there is a pulmonary conus full, pulmonary artery hypertension, inverse Mostich sign because all the pulmonary vessels they are going upward, and pulmonary edema, Carle B lines. So, these are these things you can get in the X-ray chest of the mitral regurgitation. In ECG, P mitral, atrial fibrillation, RVH and left ventricular hypertrophy also. In echocardiography, you can see there is a regurgitation jet from LV to LA. The treatment again, the treatment, medically treatment. So, we give the beta blocker. If the patient is in AF with fast ventricular rate, we give beta blocker, we can give the calcium channel blocker, or if the patient have the pulmonary edema, we can give diuretic. But if the patient is not become symptomatically better with the medical management, we go for the surgery. So, again surgery, the same valve, if there is a rupture or the perforation of the valve, we can do the repair of the leaflet perforation, we can do the annuloplasty, or if the patient have both MS and MR and the valve is not repairable, then we do mitral valve replacement. So, this is all about the mitral stenosis as well as the mitral regurgitation. If you have any doubt, you can ask me. Otherwise, anyone come for the attendance? Please, attendance ले लीजिए. So, clear? Any confusion with the MSMR, etiology, clinical presentation, pathophysiology, hemodynamics, any sign?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53, 54, 55, 56, 57, 58, 59, 60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77, 78, 79, 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 93, 94, 95, 96, 97, 98, 100, 101, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 21 batch 20, 30, 95,
Your badge is not posted in clinical, posting in medicine? Any one of you? We always have very good cases of the valvular heart disease. So if you are interested, clinical auscultation, you can come anytime in the ward. There are many cases. थैंक यू. क्या हुआ? अच्छा माइक, अरे बाप रे.